Welcome everyone again to the University of New Mexico Law and Mental Health series. These are weekly discussions of practice and science by experts in behavioral health and the law. This is a series hosted by the University of New Mexico Department of Psychiatry and Behavioral Sciences, along with the New Mexico Behavioral Health Services Division. I'm Anthony Perillo, the Forensic Psychology Training Director here at the University of New Mexico in our Department of Psychiatry and Behavioral Sciences. For our talk today, if you have any questions for our presenter, make sure you enter them in the Q&A box below, not the chat box, but the Q&A box. Our presenter welcomes questions as the talk goes on, so feel free to enter them at any point. We might disperse some of those questions throughout the talk and then hold some till the end. Oftentimes, it's not possible for us to get all of the questions in. Just forgive us if we don't get to yours. If you are pursuing continuing medical education credits, there will be a sign-in sheet that's posted in the chat box shortly, so keep your eye on that. If you're pursuing APA continuing education credits, that will also be in the chat box, the link for that, but in the latter portions of the presentation. So keep your eye as the presentation's wrapping up for that CEU link. Save that link if you're not able to access it right now, and make sure that you save a copy of your certificate after you complete the survey, because we don't have access to the certificates after the fact. As a heads up, the recording link and the PowerPoint slides for this talk should be available sometime later this week. And for next week's talk in the series, we have Dr. David DiMatteo, who'll be providing us some insight on those specialty guidelines of forensic psychology we've been looking for updating for quite a while. But let's circle back to this week. I'm very excited to introduce you to today's speaker, who'll be discussing measurement of sexual victimization and addressing disclosure issues and ultimately issues of equity. This is Dr. RaeAnn Anderson. Dr. RaeAnn Anderson is a licensed psychologist and the principal investigator of University of North Dakota's Sexual Violence Prevention Laboratory, and soon to be moving to the University of Missouri Kansas City School of Nursing and Health Sciences. Dr. Anderson's research addresses measurement of sexual violence, dissemination, and implementation of sexual violence risk reduction interventions for marginalized populations, as well as identifying new targets for perpetration prevention. Her research has prompted major changes in the field, evidenced by her inclusion in the Sexual Experiences Survey revision team. Her work on measurement has especially demonstrated the need for approaches to improve recognition and inclusion of LGBTQ+ individuals and men's experiences of sexual violence. She's founder and originating director of the Northern Prairie Community Clinical Dialectical Behavior Therapy Program, the only adult outpatient DBT program in the state of North Dakota at this time. She's garnered nearly $1 million of federal, state, community grants to support her research, including the NIAAA Career Development Award. She's received national recognition for her service to the Association of Behavioral and Cognitive Therapies, and was awarded the University of North Dakota Foundation Undergraduate Teaching Award in 2022. When not spreading the joy of science on her campus and her future campus, she enjoys corralling her rambunctious and curious 5-year-old, hiking and crafting. So Dr. Anderson, RaeAnn, on behalf of the University of New Mexico, very thankful and excited for you joining us and sharing your expertise with us today. I will go ahead and throw it over to you.
Thanks, everybody. It is slightly embarrassing to receive such a warm and comprehensive introduction. And I've seen some of the other speakers that have been invited to participate in this, and I'm very honored and excited to be here. A reminder for those who want continuing education credits, how to do that. And there'll be a QR code at the end. No financial arrangements brought me here. And the views expressed today are solely mine and don't represent the University of New Mexico in any way. Our learning objectives: be able to understand the difference between behaviorally specific versus face valid sexual violence measurement, differentiating unintentional versus intentional barriers to disclosure, which I expect this audience will be a little more familiar and expert on those ideas. And then finally, being able to describe some of the mechanisms of measurement design that help us address these unintentional difficulties in disclosure. And that's the outline of how we're going to get to those objectives. So I will start right off the bat with this whole line of research. My whole lab is really informed by thinking about rape as not just a trauma, not just a crime, but also a health disparity. Want to review just to make sure we are all on the same page. So I'll try to actually shy away from saying victim or survivor to just say people who have experienced sexual victimization. Because research suggests that neither label is widely endorsed. I think of sexual violence as an umbrella term that captures lots of different forms of violence that are all problematic, and use the term rape to describe the most violent form. Anthony and Shanti, it says I have a microphone issue. Is that true?
I'm hearing you fine. I'm not sure if
My
it turned off when your
having a
video turned
small
off.
panic attack or something, but I
Yeah.
want to make sure.
Mhm.
And then finally, I'll try to use the terms victimization and perpetration. These are not interchangeable terms, but when sexual violence occurs, those are two different experiences. Two sides of the same coin in some ways. All right, this audience knows well that rape is a crime. It is also a cause of health problems. Pretty much every disorder and diagnosis that has been studied in relation to rape increases the risk of, from gastrointestinal disorders and diabetes to the things that we study and treat a lot, things like post-traumatic stress disorder and depression. And according to federal governmental health agencies, health disparities are health outcomes that vary between populations. And as you can see in the table here, rape does not affect populations equally. We have a huge difference in the prevalence rates of rape between men and women, and also when we include our trans and gender non-binary peers. Thinking about other areas of identity like sexuality and race, we continue to see disparities. Bisexual women, at least 50% experience rape. 80% of Indigenous women experience some kind of sexual victimization. Gay men are more likely to experience sexual victimization than hetero men. Mixed race, immigrant folks, people with physical disabilities, people who are unhoused, all of these groups of people are more likely to experience rape than the average person, or than the national prevalence rate. So rape is very much a health disparity, and this health disparity falls along those lines of social power and marginalization. Which may lead you to wonder, why are we talking so much about measurement today? But I hope that this talk demonstrates how measurement is actually part of how we solve these health disparities. And then I'll start with a study that kind of got me into this game. How did I get started doing measurement research? That it was not my ambition when I started graduate school. So in between my thesis and my dissertation, I thought, I'll do a little study to see, do gay and bi men, are they more likely to experience sexual assault? That was not really something we had an answer to at that time. So I thought, I'll do a quick, little survey study. The hubris of youth was nor quick nor little and taught me a lot. And the main things we found here was that the reported rates of victimization were much higher than we previously thought. Research at that time suggested that a prevalence rate would be about 14%. We found about double that. And while I had included at the time, gold standard measure of sexual victimization, the 2000 Sexual Experiences Survey, short form, I'd also include the revised conflict tactics scale, thinking that that'd be a nice indicator of validity, because at that time, there was no data on the SES with men. But what we found was that the revised conflict tactics scale, which should only capture incidents related to romantic partners, whereas the SES would capture romantic partners and all of these other relationships, the revised conflict tactics scale was actually producing a higher prevalence rate than the SES. And had I not included it, I would have incorrectly classified about 14% of the sample as having not experienced victimization. That's huge. That we found almost double the expected prevalence rate, and it was not coming from the measure That's supposed to be the gold standard, the best way to do things. So that told me that something is up in our methods, and I wanted to dig into that.
All right, Dr. Anderson, someone wanted to clarify for those 397 collegemen you referenced, were they all identified as gay or bisexual?
Not all. It was a mixed sample. I want to say it was in the ballpark of 25 to 30% identifying as gay or bisexual, and we found a higher prevalence rate for that group.
Thank you. And I think you're going to be getting to this, but somebody asked if you could share how underreporting may differ across different identity groups.
We will get to that. Excellent
Indeed.
question.
All right.
So I learned from this that something is up in our methods. Something is awry. And this really disturbed me because measurement is really the core of any research enterprise. Otherwise we're misestimating effect sizes, we're missing cases, we're missing effects. Like, are we even doing science if we are not confident in what we are measuring? And particularly with this kind of sensitive topic, if I'm going to say this number of people were raped, or alternatively, thinking about perpetration, this number of people raped, I want to be very confident in that judgment. So, even though the Sexual Experiences Survey is considered a behaviorally specific measure, I want to give a little bit of background on what that means and kind of how we learned that, just to make sure we're all on the same page for some of the data I'm going to dive more deeply into. So how do we know what we know about any of these things? As psychologists, we're typically doing interviews, we're giving self-report questionnaires, we're observing people's behavior. These typical modes, are not equal for all problems. That's perhaps especially true for sexual violence. That interviewing people is hard, that observing is nigh impossible. Because we have these really well documented effects that some people do not want to reveal this information for lots of reasons, and stigma being a huge reason. For example, one research study suggests that at least 23% of women in a healthcare seeking sample say they would not tell the truth if their provider asked them about this. We also know from lots of great qualitative research that even when people want to tell, it can be really hard to disclose. So we've developed this wealth of research demonstrating that using behaviorally specific questions helps address this problem, helps make it easier to disclose. And this has become the basis for basically all research in this area, as well as public health surveillance, because of the Sexual Experiences Survey and the data and the development that went into that. Now the CDC uses a behaviorally specific approach to do public health surveillance of how many people in the US experience sexual victimization. I'm young enough that this all, I'm standing on the shoulders of the giants who did this. But I think it's worth remembering that previously, when we were trying to understand how many people experienced rape, we were relying on police reports. Probably don't need to tell this audience how problematic that would be for a variety of reasons. But in brief, who reports to the police is not the average citizen. And the percentage that gets reported to the police is a fraction of the overall total that actually occurs. And we find that using self-report measures compared to more straightforward face-valid measurement increases the endorsement on orders of magnitude, that your prevalence rate will be literally 10 times higher by using behaviorally specific language. So what do I mean by that? So here's an example of a question that we would ask that would help us determine whether someone has experienced rape. And this is typically given in a questionnaire, not something that you read out loud, but you give someone a questionnaire with questions like this on it. So this describes anal rape by means of taking advantage of someone's substance use incapacitation without ever using the word rape. This is consistent with most legal definitions when that is of concern. This is what behaviorally specific language item would look like. That is a contrast to a face valid item, like, have you ever been raped? Which for some people is going to feel more like, have you ever been raped? It's a very loaded emotional question. Could come with a lot of stigma. Because even if you're willing to put that label on yourself, to take on the burden of that stigma, it's not actually just about you. Because think about the scenario most rape happens in. Most of the time, the person who raped you is someone you know. Your friend, your partner, maybe your best friend's brother, an acquaintance. And so by taking that on, by saying, yes, have you ever been raped? You're not just calling yourself someone who's experienced rape. You're also calling that person a rapist. It's hard to do that. And so that is the beauty of behaviorally specific language. And we think that it's so much more effective for two big reasons. One, of being able to kind of cut through or pierce these stereotypes or stigma about what rape is. By not even using the word rape, we're kind of stepping aside all of that and just saying, what about this experience? Did that happen to you? We also think that it helps facilitate accurate memory recall. We know that sexual victimization tends to be a repeated experience, and that when we think about memory recall, our brains store similar things together. And so this also facilitates accurate memory recall and helping us kind of go through the list of, okay, all of my different sexual experiences, which ones involved this? So instead of have you ever been raped, and you might think of an image on the left of the screen of someone looking scared, being followed in a parking garage, that's just not even coming to your mind. It's not even coming to your mind of, well, was it really rape? Because I didn't scream. And I don't know that I have proof. Sidestepping all of that. And instead, being able to filter through all of the potentially relevant memories to get to the very exact behaviors we're interested in. So I want to give one example of how this might contrast to a more face valid approach with something that I know we use in our clinic here, the life events checklist. This is considered a kind of standard trauma history screening measure. It's recommended by the National Center for PTSD. When you survey clinicians, it's one of the most frequently used trauma history questionnaires, and it's been cited in nearly thousands of studies at this point. And on the right side of the screen here, I have the exact items from the measure. So it has this item, and then you check a box of, did this happen to me? Did this happen to someone I know? Did you witness this? So sexual assault, parentheses, attempted rape, made to perform any kind of sexual act through force or harm. So you can see here that it starts with some face valid language and gives some specifics about behaviors at the end there, that sexual act through force or threat of harm. But in contrast to the sexual experiences survey and related measures, this doesn't quite match onto legal definitions. And by mixing those two kinds of languages together, it may be less effective. We don't have a ton of data comparing these two things directly, but one study did compare these things two directly. We compared the behaviorally specific approach, like the sexual experiences survey and the life events checklist, in two samples that are both high risk for substance use and health disparities. And consistent with hypotheses, we found that the behaviorally specific measure outperformed the life events checklist, and that this effect was a lot larger for men. We also found effects here for the number of traumas and for alcohol-related violence, that the more traumas someone experienced, the more likely they were to endorse face valid items. And the other thing we found was that the life events checklist was really missing alcohol-related violence experiences. I'll give another example of contrasting these approaches with the National Comorbidity Survey replication, which was the standard for decades in how we estimated the prevalence of psychiatric disorders. And a ton of research has been conducted linking trauma, including sexual violence, to psychiatric disorders. And the two items from the National Comorbidity Survey are here on the right side of your screen. Have you ever experienced rape? We define this as someone either having sexual intercourse with you or penetrating your body with a finger or object when you did not want to, either by threatening you or using force, or when you were so young that you didn't know what was happening. Did this ever happen to you? A lot packed in there. We do have some behaviorally specific language there, but it's comboed with a really stigmatizing word, and it's just long. There's a lot happening there. So this is what the National Comorbidity Survey estimates look like compared to estimates using the Sexual Experiences Survey with college students and current CDC estimates for rape. And you can see here that those two items from the National Comorbidity Survey are pretty wildly underestimating sexual violence in the general population. So not only is behaviorally specific language much more accurate, it's more equitable because research has demonstrated that difference in who will endorse face valid items versus who will endorse behaviorally specific items varies a ton across populations. Anywhere from 95% to 20% of cases will be missed if you just rely on a face valid item like, have you ever been raped? So we're definitely underestimating the problem, perhaps vastly underestimating the problem, and it's not equal. It's not equal. So how do we address this? So this gets into the problem of unintentional versus intentional disclosure. And both those disclosure problems can be caused by things within the respondent themselves in terms of their choosing not to, or they're not reading closely, but it can also be caused by researchers and clinicians. And these disclosure problems are, again, not evenly distributed across the population. So thinking about reasons for unintentional non-disclosure, this stigma and that kind of emotional valence of the word rape, that is not evenly distributed. It's much higher for some communities and some health disparity populations than others. Similarly, memory errors are not evenly distributed. Researchers also contribute to this when we use biased definitions in our research. For example, the federal government definitions of rape do not include rape when you are forced to penetrate someone else's body, which is one of the most common forms of rape experienced by heterosexual men. It is also more frequently experienced for gay men, bi men, and sexual minority women. And when we use non-inclusive research designs like only including women in a study on rape, there are sometimes good reasons to do that, sometimes bad reasons to do that. Anthony, did you want to jump in with a question?
Yeah, someone asked about with these trends, do you think this is more about people being uncomfortable labeling their experiences in a face valid way, or is it more an issue of insight with participants not seeing what happened to them as sexual violence? Person adds, I guess what I mean, would the participants who are categorized as having experienced sexual assault be surprised to know their experiences were being labeled as sexual violence or maybe as serious sexual violence?
Yes, in general, it appears that this is mostly an unintentional disclosure problem, that people are not tagging these experiences as rape, as sexual assault, sometimes not even as negative. I've had a lot of participants say things to me like, well, that's just what sex is. People take what they want.
Thank you for that.
Intentional non-disclosure has a little bit different causes in terms of, there may be legal consequences, there may be social desirability stuff happening separately or in concert with stigma. And researchers sometimes accidentally elicit intentional non-disclosure when we change standardized forms, when we cut things to make it briefer, we're not giving people the opportunity to disclose, and we are sometimes unintentionally sending messages that discourage disclosure. So we're going to get deeper into that in terms of how can you address these barriers in the questionnaires that you use? How can we make behaviorally specific language even better to address the entire range of sexual behaviors, coercive behaviors, consent? How can we structure our questionnaires to deal with these issues of unintentional disclosure, which is what I'll mostly focus on today. And I will also mention that the bogus pipeline paradigm, where you tell someone they're connected to a lie detector when they are not, is an excellent way to address intentional non-disclosure. So, behaviorally specific language is great and it can go a long way, but we have to describe everything. So one area that our lab has identified as not having been equitably included is the entire range of sex acts. In the past, sex acts that are consistent with FBI and related definitions of rape, which assume that it's a cisgender heterosexual woman being raped, were the only sex acts that were described in questionnaires. So we conducted a study where we wrote 4 new items that were designed to reflect made to penetrate rape, a form of sexual violence that is more often affects men and sexually minoritized individuals, people who identify as gay, lesbian, bi, queer. And in a sample of about 1,500, this included college students, about half college students, half MTurk workers. Had made to penetrate acts not been included, almost 11% of men in this study would have been classified incorrectly as having not a victimization experience. And when we looked amongst our population of men who reported victimization, approximately 40% of them reported made to penetrate incidents. So if we're leaving made to penetrate out, we are creating an equity problem by not capturing men's experiences and the experiences of sexually minoritized folks.
Yes, Dr. Anderson, someone referenced for the slide before that saying the slide seemed to say 95% of heterosexual men underreported rape on them. We're wondering if this might be accounted for a lot of tacit homophobia, basically not feeling safe telling about it, but regardless of how they actually felt about it. Is that
possibly?
Okay.
Possibly homophobia. I think it possibly not including things like made to penetrate on these questionnaires. In general, men seem to struggle to see themselves as victims. And so we have to have really good behaviorally specific questionnaires to make it really valence neutral and not a big deal to check, yep, that happened to me. Good question. Another way we can improve behaviorally specific questionnaires is by making sure we're trying to overcome any stereotypes about who the perpetrator is. So, right, our kind of stereotypical perpetrator, or the rape myth, is that it's kind of strangers in the dark. And so that could unintentionally mean that intimate partner perpetrators are not captured. So we did an experiment where we just added a column on the sexual experiences survey that said, did this happen? How many times did this happen in an intimate relationship, which was defined earlier, and not in an intimate relationship? And we found that that simple modification increased reporting of sexual violence. Again, coming back to equity here, sexual minority folks are more likely to experience intimate partner violence. We also want to be behaviorally specific in our consent language. So some questionnaires have used the word want, of when you didn't want to, or sex that was unwanted. But unwanted is a bit vague, and it can conflate consent with sexual desire, right? So for example, if The Rock rolled in my office right now and asked me to have sex with him, I might want to, but I might not consent to that because I'm in a committed monogamous relationship. That's what I mean by this want can mean sexual desire, and it can mean consent. So a study folks did was, instead of using the phrases that I underlined when you didn't want to, they changed it to after resisting, did this thing happen? And we found that that was, or Roof and Gross found, to be clear, found that after you resisted was much more effective in identifying cases of sexual victimization, particularly unwanted touching. And we don't know as much about equity related issues with this consent language, but I would hypothesize that this would be most important for folks who are stereotypically given less sexual agency or who experience more stigma around sexual activity. So those are language issues. I want to switch gears slightly to thinking about questionnaire design and how we structure questionnaires. So we can also structure our questionnaires in ways that unconsciously or implicitly suggest that the things we're asking people about are common and no big deal. So one way to do that is the response format that we use. So saying, how many times has this happened, implies that you think it's happened, versus has this ever happened suggests that you think it's common that it will not occur. And so we randomly assigned 355 adults to these two different response formats. Otherwise, the behaviorally specific language that people received was exactly the same. And I highlighted the table from the paper here, but the short version is response format really matters. Matters a lot. It especially mattered for men, that in the yes-no dichotomous condition, 23% of men reported victimization versus 39% in the scaled response format condition, nearly doubling the prevalence rate for men. Slight numerical difference for women, but that was not statistically significant. I also want to point out too that we found an effect for verbal tactics. When we asked people about sexual behaviors that they were forced to do because of things like verbal pressure, being called names, things like, I'll break up with you if you don't do this. We found a large effect there too, of 30% in the dichotomous condition versus 41.5% in the scaled condition. And I think that speaks to how just normative some of these behaviors are. You know, verbal tactics are pretty mainstreamed in our culture, that badgering someone to have sex with you is, I mean, the basis of many sitcom plots and romantic comedy movies, and not seen as coercive. And so having that kind of thing on a scaled response format allows people to overcome that stigma. Yeah, that has happened to me. So with this study, we weren't well powered enough to test for other population effects besides gender, but I would hypothesize that this might be most impactful for populations that feel the stigma the most. Another design feature that we can address is the number of items we include. So the more items in that kind of same topic or same theme, it can potentially imply that it's normative. In other words, using kind of gate questions or screening questions can be problematic. Thinking of that national comorbidity survey item that I showed you all earlier. I mean, that was long, that was a mouthful. So this is kind of a visualization of what gate logic might look like in survey design versus giving a complete list. So in gate logic, if you say yes to that initial screening question, you then get more questions and, you know, branch out here and there. Versus you just get every question at once. Here's an example of this from national data. So the National Crime Victimization Survey, one of their sexual violence questions is on the left there. Excuse me. And you can see that this is a long question. That's a whole paragraph. So it's also just a lot cognitively to be trying to process and understand which may apply to you. And it has the context given here of it was a crime. So not only is it cognitively complex, it is potentially activating those stereotypes and stigma around a crime. On the other hand, we have the National Intimate Partner and Sexual Violence Survey that the CDC uses for surveillance data. And they approach this with how many people have ever done any of the following things when you didn't want it to happen? And there is a list of 17 sexual behaviors. And this is the difference between those two approaches, that we are literally 10 times greater number of cases being identified in the CDC data versus the National Crime Victimization Survey. And what's amazing about this particular comparison is these are both repeated studies that are ongoing right now. So we're able to make this comparison in close to real-time data, that this is not an effect of time or cohort or generation or just, our changing cultural norms. This is a measurement issue. I will note here that, we have the normative design issue, but we also have the priming of stigma with the word crime. That could be, there's probably multiple things happening here. And as we are wrapping up, I wanted to make a quick note on measuring perpetration. I really focused on victimization findings today for a couple of reasons. Mostly the data. In the sexual violence literature, this was a study from several years ago now, but at the time, they estimated that 70% of research on sexual violence was on victimization specifically. So we have just much less research to guide us. And I know particularly for some of you forensic practitioners, that's your bread and butter, is the perpetration side of things. So you all are the ones who are generating much of that research. But we just have much less research to guide us on how to measure perpetration. But we hypothesize from existing data that most of the same rules apply in terms of unintentional non-disclosure still being a large barrier. But now intentional non-disclosure is an even bigger threat. And I want to highlight Strang and Peterson's study here, where they did a bogus pipeline study with a sample of community men. And they found that in the bogus pipeline condition, so the condition where folks thought they were connected to a lie detector, that increased reports of verbally coercive, of illegal behavior, of things like physical force, of things like substance use incapacitation. It had no effect on verbal coercion or verbal tactics. That is how kind of normalized and mainstreamed verbal tactics are, that in a bogus pipeline paradigm, there was no difference between the two conditions. There was a big difference between the two conditions in reporting on those things that are more consistently illegal, like using physical force. So we have some evidence to suggest unintentional non-disclosure is still an issue from some of the research I've done, some of the other research that's been done. And we have research from bogus pipeline studies suggesting that this intentional non-disclosure is now an even bigger threat. So to sum up, and then it looks like we're going to have lots of time for questions, which I was hoping for. Measurement really matters. It matters hugely. A lot of my research has really highlighted how our existing questionnaires have really been designed with cis heterosexual women's experiences in mind. And they've almost exclusively been tested and developed with cis heterosexual college women. So it should come as no surprise then that these questionnaires do not operate the same way and are not capturing experiences of other folks. And our research has demonstrated how we're really specifically underestimating the experiences of heterosexual men, of sexual minority men, and sexual minority women. But when we are relying on these standard approaches, we're not getting the full picture. So inclusion really matters. Questionnaires should be able to capture anyone's experiences. I'm doing a project with some Indigenous communities right now. As far as the existing data goes, CDC says that Indigenous folks are the racial group most likely to experience sexual violence. Right? We get prevalence rates for women of 80% and like 40% for men. And yet, our questionnaires have basically never been tested or examined with Indigenous folks. So what are we missing? We have to be inclusive during the development of questionnaires and in our ongoing research. So while we know measurement matters and we have some ideas about where we're missing and where we need to do better, there are still a lot of unanswered questions. Particularly a weakness in my line of research is that we often are combining sexual minority groups when lesbian women and gay men are probably having really different sexual violence experiences. Similarly, we have almost no data testing things between racial groups. And we also need to think about other cultural groups too, in terms of, I saw a paper recently that was focusing on sexual violence among the Amish community, right? The language that people are going to use and be familiar with to talk about sex varies a lot based on your cultural context. And they wrote a really interesting paper kind of digging into how might we need to ask about these things differently to account for that particular culture. We need to be doing more of that kind of research to really understand how to recognize these problems and be able to, in my opinion, prevent them. We need a recovery and rehabilitation too, but prevention, an ounce of prevention is worth a pound of cure. And there's that evaluation link. And now we have about 15 minutes to chat and ask and answer further questions. Thank you all.
Wonderful. Thank you so much, Dr. Anderson, RaeAnn. This is just really eye-opening in terms of our fundamental understanding of not just sexual victimization, but how this could translate to a number of issues. A lot of it ending up being rooted in the very questions that we ask. And you can see this resonating, whether it's in research or in your actual clinical interviews, that the information you get could be only as valid as the considerations that go into how you actually try to get that information. So the numbers here are quite strong. Thank you for providing all of this information for us. As you see, we do have a number of questions here. In the meantime, for everybody, the CEU links are in the chat. If the link isn't working for you, the link does work. I would then just encourage you to save it later, try it again in a different browser later on, but make sure that you have access to that link before you leave the webinar. Somebody noted near here at the end that they'll read the references, but wanted some clarification, something that you referenced very early on. Could you explain briefly why the term survivor is not preferred?
Sure. I'll go back just because we did fly through these slides. This has been a couple of small studies on this, but so the history here is that feminist psychologists and activists in like the 70s kind of originated the term survivor and promoted the term survivor with the thinking that victim implies a kind of passive state that could impede recovery of the problems that rape causes. But recent research, including some data in my lab that we're in progress of publishing, it's something like 25 to 30% of people resonate with the term victim, and just 30 to 40% with survivor. So there's not one label that a majority of people are really feeling like fits them. And we're still digging into kind of people's reasoning why, but one of the things that, in my opinion, this is me speaking as a person, that I don't love about the term survivor is that that's also what we would say for someone who, like, survives a hurricane. That is a natural disaster that, things that are random acts of nature, although with climate change, there's more blame to go around than there used to be, versus something like rape where somebody did this to you. So the term survivor really eliminates some of that responsibility. And that's, I think, part of the reason some folks don't dig it.
Thank you for that clarification there. This is a broader question that doesn't touch on this term specifically, but I could see how, again, we're getting into how language and framing can impact perceptions. Somebody asked if there were any differences in outcomes associated with different methods of asking about or labeling sexually violence, like behavioral versus face valid. That is there any evidence that the self-labeling of an event in a face valid way, like labeling what happened to myself as rape or sexual assault, is a causal factor for some of the negative outcomes associated with sexual violence?
Short answer, yes. There's actually a large literature on what the literature usually uses the term rape acknowledgement. Like, are you willing to say, like, yes, I was raped? And studying a range of health outcomes and coping, it's mixed for some particular outcomes. Like, some research says people who are acknowledged have more PTSD symptoms. Some research says less. I think probably the big complication there is time. That the longer since the event, there's just 2 studies, but 2 studies that suggest the longer since the event and the more people you tell and kind of the more help you get, the more comfortable those kinds of labels become. So we have some confounding there in terms of label and time and what's happened in between the rape and the time of the study. The most compelling finding, I think one of the most important findings from that literature that is less conflated or confounded by time, is likelihood of experiencing rape again. So for about 60% of people who experience sexual violence, it happens more than once. And people who don't acknowledge, who are like, no, I wasn't raped, but when we give them behaviorally specific questions, they do in fact have an experience of rape, they are more likely to experience rape again. So there is some value in getting people to, the research suggests doesn't necessarily have to be the word rape, but a word that rape, sexual assault, and crime. Like, if you label if you're comfortable with one of those labels, you're less likely to experience rape again.
Thank you for that. Somebody prefaced wanted to make sure that you saw a really interesting talk, and then regarding asking about any data or information on the retest reliability of these modified measures, or other considerations of test taking validity like attention checks or reverse scoring, particularly on some of these studies that used a lot of similar sounding items.
Yes. Test, retest. Speaking of my heart. Speaking of my heart. There's very few test retest studies. I think I've written half of them. So I am intimately familiar with the test retest research. One of the papers I wrote on this, and I will say all of my papers on this, and they're the most recent ones, have the methodological flaw of we lost a lot of people in that 2-week follow-up period who just didn't complete the survey again, even though they were in some cases professional survey takers and paid. But and one of them, we tested whether they kind of got the number of items they completed. That was not related to reliability estimates. The shorter form was as reliable as the longer form. That's just one study. And there are some other, methodological pieces within that to consider. We just don't have a ton of retest data. It doesn't seem to be super valued by the folks that are doing this research. We have a lot better research on kind of validity in terms of, is endorsement related to things like health problems, buckets of data on that. Let's see, what was the other piece mentioned there of psychometrics? Anthony, you want to remind me?
I'm going back to the one I archived here.
Yeah, if you
Use of attention checks, reverse
use of attention checks.
Yeah.
More and more research is using attention checks. I don't know that I know of a study where people compared non-attention checked data to attention checked data on psychometric kind of outcomes, but at least I can think of several papers off the top of my head reporting on psychometric properties where they did have attention checks in the data.
Excellent
question.
How much is disclosure, from your understanding, related to the gender of the person asking the question? The person that asked this question originally asked about if women's reluctance to disclose is related to the gender of the person asking the question. But I guess with us talking about all these intersectional natures here as we went further in the talk, does the gender of the person asking the question factor into disclosure?
I can't imagine that it doesn't. And yet I'm drawing a blank of empirical support for that statement, partially because in my research and even in my clinical practice, I am almost never asking people these questions in like an interview. It's always questionnaire, because of the research suggesting people disclose so much more in the questionnaire format than they would being asked out loud. But I don't know that there's particular data to answer that question. And that's an interesting question, because you can think of even if it's a questionnaire, did a man hand it to you, or is the researcher's name stereotypically male? All of that could affect test taking response.
Yeah, thinking about the awareness of who is going to receive that information may certainly factor in. Somebody asked if you've considered extending this research to correctional settings. So they work in a men's prison and note a high prevalence of sexual assaults to both men and trans female incarcerated individuals.
Well, call me, please, because we're doing a validity-focused study right now where we are giving sex offenders and college men and community men all of the victimization and perpetration questionnaires and interviewing them about what they endorse and, seeing how valid are these measures in capturing the experiences of different folks. I am especially passionate about that because I hear in the research and from my colleagues all the time, well, sex offenders are different. And, I don't know that the sexual experiences survey really matters for them. Are they different? That's an empirical question. Like, let's collect the data to see. And I have not been able to find very many papers on the topic. I've only been able to find actually like one paper that actively compares folks with sex offense convictions to community men for perpetration, and they found very few differences. So there's not been a ton of research with forensic populations testing the psychometrics of these questionnaires and just making sure that their experiences and these are folks who tend to be racially minoritized and economically marginalized, are they captured on these questionnaires? I would suggest that they're probably not completely, based on my experience with Indigenous folks who've told me a lot of power abuse stories, that the sexual experiences survey does not even have an item on misuse of power. But Cindy Struckman Johnson at University of South Dakota is one of the people that is doing that work. So I'd also recommend you check out her research.
Representation for one of the other Dakotas. Thank you for that. Yeah. Somebody asked if you have any recommendations for one or two screening victimization questions for adults. men and women, unknown sexual orientation, and juveniles in criminal forensic evaluations of defendants. Is there any particular victimization screening questionnaires that you would recommend?
Hmm. That's tricky. If you want it to map onto legal definitions, the sexual experiences survey is your best bet. And I would pull one alcohol item and one verbal tactics item, because those tend to be the most frequently endorsed. We're developing a short form of the sexual experiences survey. Right now, it'll be 4 or 5 items. I'm on the team doing that, but it'll be a little while till that's available. But the tactic first sexual experiences survey, there's good psychometric research on. So I would pull items from that you think are appropriate for your population. If you're willing to give something that's a little longer, the post-refusal sexual persistence scale is, in my research, more preferred by the people filling it out. They find it easier to understand and disclose more on it, but it is not as specific to legal codes. So there's kind of a balance to strike there depending on what you need. And there's a brief form of that that's like 5 items.
Excellent. Thank you for that clarification there. Somebody asked on the therapeutic side of things here. Curious if there's been research on use of behaviorally specific measures on assessments or intake for therapy services. Is this recommended? I think here we're getting at this, the value of language and disclosure. Is this behaviorally specific measures recommended for like intake for therapy?
Yeah, I mean, I would, and I do. That's just, again, like people can only tell us about what they've recognized. And I have many a time had patients who, find out many months later experienced rape. I can think of one in particular that I did, she had done like a year of intensive outpatient DBT, and then I was seeing her for individual trauma-focused stuff. And, as we were starting, she was focusing on some of the extreme physical, intimate partner violence she experienced. And in talking about that, she used terms like, he took sex from me. Now, this person had been in a year and a half of therapy at least, who was talking about, being frankly almost murdered, still couldn't say the rape word. So yes, I would recommend it. And I'd recommend you talk to somebody like me to collect data as you're doing it, because there's just very little research about what are best ways to do that. What do we get from it? What do patients get from it? So again, call me, I'm available, and I'd recommend it, but please share the wealth of data with us. So there's not much out there.
Certainly. And as we wrap up today, since we are at the top of the hour, the person that had asked about the question about clarification on the 95% of sexual violence from heterosexual men being underreported, wanted to know if you had a particular reference in the slides for the stat. They said they have a male forensic patients who often underreport, and they're interested in sharing this kind of normalized information with them.
Anderson et al. 2017 would get at that, and our time et al. 2014, ARTIME.
Wonderful. Thank you for that. Well, Dr. Anderson, RaeAnn, thank you so much for all this really helpful information and for the contributions that you've made along this. I can see whether it's climate surveys in universities, whether it's within correctional populations, people that work in community behavioral health, how many different ways this can, make us really consider and being careful about how we approach and ask things. We can only help with the information that we have. The information we have is going to be only as valid as what is understood and processed and received by the people that we're talking to. So Really, really helpful, insightful information here. Thank you so much for sharing all of this with us.
Thank you all for listening. I really enjoyed this. I'm again just like pleased as punch to have been invited to be part of a series that there have been greats presenting in as well. And thanks you all for your great questions.
Thank you so much. That wraps up this week's Law and Mental Health series. We hope to see you next week when Dr. David DiMatteo will be providing us some insight on those specialty guidelines for forensic psychology that we've been updating for quite a while. So until then, we hope you have a fantastic rest of the week. Take care and good health.